Dr. Araneta received the 2014 American Diabetes Association's Vivian Fonseca Research Award for research on diabetes among Asians and Pacific Islanders, and the inaugural Wing Family Lectureship at the Joslin Diabetes Center at Harvard Medical School in 2017. She was appointed to the NIH Advisory Council for the NIH Institute on Minority Health and Health Disparities, as well as the NIH Council of Counsels. So everyone, please give a warm Zoom welcome to Dr. Araneta. I will stop sharing my screen, and Dr. Araneta, please feel free to start your presentation.
Thank you so much, and thank you for this opportunity to share my path and some of our research findings with you. When I was in graduate school, we didn't have a forum like this, so I'm delighted that you all have an opportunity to get together to learn from each other and to become inspired. So I'm going to, and feel free to interrupt me. I might not be skilled enough to look at the chat box and manage my slides. So John, if you wouldn't mind monitoring the chat. So I was asked to talk about my path. First of all, kumusta, magandang hapon, maayong hapon. I was born in the Philippines to parents from the island of Negros. So we spoke Ilonggo at home, spoke Tagalog when growing up in Manila. And then we migrated to the US when I was 10 years old in Berkeley, California. I attended middle and high school in Palo Alto. And so people often ask, well, how did you become interested in epidemiology and public health? It started really from my lolo. So my father's a physician. He was a neurologist in the Philippines, a psychiatrist here. My tita's also a neurologist. Lolo was a pediatrician. And at the time, when we were getting our independence from the US, they wanted a medical system that was patterned after the United States. So he was offered a position as the Minister of Health of the Philippines. And he went to Berkeley to get a degree in public health, ended up going to Cambridge and really liked the idea of socialized medicine. So he went back to the Philippines and was trying to introduce socialized medicine, but we were still a neo-colony. The Americans weren't receptive to that yet. So he never served his term as Minister of Health. But what he used to do is, there's this old bakery in Manila called Las Cibeles, and they have the best churros. So he would ask all of us, how many of you want churros? I would raise my hand. But the catch was we had to do rounds with him at Philippine General Hospital, where he and Papa were both faculty members. And the lessons that he left with me were, we are a resource-limited country. Look at all those people standing in line for their tuberculosis treatment, when it's actually more urgent to provide them with housing that is spacious, or it's more urgent to address the structural determinants of health. Give them adequate food, adequate jobs, pay them well, and prevent disease rather than treat them after they're ill. So that was really my introduction to public health. So after high school, I ended up here at UC San Diego. I was a biology major and spent a year at Syntex Pharmaceuticals, learning about toxicology and clinical trials. You all belong to the COVID generation. That's a part of your education, part of your training, that might influence the direction of where you want to go professionally. For me, it was HIV. And so at the time, it was still unclear why certain communities were at higher risk than others. That's the first time I learned about infectious disease epidemiology. So I went to Yale, got my master's in public health, was working for the Department of Health in New York City, looking at nosocomial infections. Why were people with HIV acquiring Legionella pneumophila, for example, and getting water samples from cooling towers. I was working on studies of pregnant women in New York City, and then I went back to Yale and got my PhD in perinatal and reproductive epidemiology. So my plan was to have a career in pediatric HIV. I worked for the San Francisco Health Department, the Los Angeles Health Department. I was working at Stanford on a clinical trial, and that's when they started introducing zidovudine to pregnant women with HIV. What happened with that clinical trial? Zidovudine was so effective in reducing viral load and reducing transmission from an infected mother to a baby, such that they had to interrupt that clinical trial because the benefits were so great. And in a span of 3 years, the number of HIV-infected newborns in California went from 1,000 a year to 45 a year. It's a 95% drop. So as you're thinking, if you're thinking you're going to specialize in something, pay attention in your other classes in case they're secure and you need to find another area of specialty. So after that, I came back to San Diego. I was leading studies on birth defects among military personnel. And the chair of family medicine at the time, Dr. Elizabeth Barrett Connor, didn't know my ethnicity. And she came up to me and she said, you know, we noticed that at the Veterans Administration Hospital in La Jolla, one of our teaching hospitals, most of the patients in the dialysis units are thin Filipino men. Were they diagnosed late? They had access to care because they were in the Navy. They had to exercise frequently. Is there something unique about the pathophysiology of thin Asians with type 2 diabetes? How would you like to work for me? And I thought, I don't like endocrinology. I don't like hormones and all the loopholes, but Papa and Lola and everyone else in my father's side of the family has type 2 diabetes. So, you know, when your Lola says it's a sign, sometimes it is. And so that was my sign. And so I continued working on the birth defect study, and that's when we started working on the UCSD Filipino Women's Health Study. So here's a pop quiz we often ask our medical students. Name the 3 ethnic groups with the highest prevalence of type 2 diabetes in California. I don't know if you want to put that in the chat, and John, if you could share the results.
Yeah, so I'll the chat as answers come in.
You could play the Jeopardy music. All right, so when you're ready, what are the 3 ethnic groups with the highest prevalence of type 2 diabetes in California?
So Angela said Filipinx, Latinx, and Black.
Okay, that's 1 out of 3 correct. So
we also had, sorry.
Oh, no, please go ahead.
We also had Native American, Hispanic, and Pacific Islander.
Okay, so that's 2 out of 3 correct. So these data are from Kaiser, Northern California Kaiser, and that includes over 2 million members. California has the largest Asian American population in the country, so we're able to disaggregate. So it shocked the medical community to learn that Pacific Islanders, Filipinos, and South Asians have the highest prevalence of type 2 diabetes in California, exceeding rates of Latinx, African American, and Native American communities, which are the groups that are traditionally perceived to be at highest risk for diabetes. And then if you look at Southeast Asians, mostly Cambodian and Thai, Japanese, Vietnamese with very low body mass and very low body mass index, Koreans and Chinese all had higher prevalence of type 2 diabetes compared to whites. It's known and emphasized in the US that obesity, being overweight, is a known risk factor for type 2 diabetes. And if you look at that orange line, that represents a body mass index of 30 kilograms per meter squared. And those in the black bars are Kaiser members without diabetes. Those in gray are newly diagnosed with type 2 diabetes, and those in white have prevalent diabetes. So you notice for all the Asian groups, they're all under that obesity line and might not be screened, might not be suspected of being at high risk for diabetes. And then if you aggregate all the Asians together, and it's circled in the red bubble, it'll look like the incidence, so these are new diabetes cases, that the incidence of all Asians together, yes, it's slightly higher than whites on the left side, pretty close to incidence among African Americans and Latinos, and then just a little bit lower than Native Americans. But what happens when you disaggregate them? Look at Filipinos, South Asians, and Pacific Islanders. Their diabetes incidence are over 50% higher than African Americans, Latinos, and Native Americans. So this is something that we've been having in these conversations about COVID risk, for example, the importance and the urgency of disaggregating Asian subgroups. When it comes to diabetes complications, you'll see that Pacific Islanders have a higher risk of myocardial infarction compared to whites. There seems to be a protective effect for MIs among Filipinos, as well as with strokes. But the real risk seems to be in end-stage renal disease. So all Asians, Chinese, Japanese, Filipinos, and Pacific Islanders have a higher risk of kidney disease compared to whites. So this is consistent with what Dr. Barrett-Connor told me when she mentioned that most of the patients at the VA were thin Filipino men who had access to care. And why were they just not screened for diabetes? Were they not treated? Or is there something that seems to accelerate kidney dysfunction? So the data I showed you earlier were from Kaiser in the year 2010. These are more updated data, 2016. And you'll see that it's the same patterns. Pacific Islanders, Filipinos number 2, South Asians number 3, Latinx and African Americans follow, and then each of the Asian subgroups exceed that of whites. The Centers for Disease Control predicts that in the year 2050, 1 out of 3 Americans will have type 2 diabetes. Among Filipinos, we're already there. We already reached that mark in 2016. The NHANES data, which are nationally based, and they have these trucks that go to different parts of the country, showed that if you look at Asians altogether, their rates of diabetes at 19% were similar to non-Hispanic Blacks. But then when you disaggregate the Asians, South Asians, people from India, Nepal, Bangladesh, and Pakistan, as well as people from Southeast Asia. And in this cohort, these were mostly Filipinos in the East Coast and in the South. Their rates of diabetes exceeded that of Latinos, Blacks, and non-Hispanic whites. So it's not limited, this excess is not limited to Asians in California. So when did this all start? The first evidence of this excess risk was documented in JAMA 60 years ago. This included 38,000 people who were living in Oahu, and it was kind of similar to a 2-hour oral glucose tolerance test. And what they found that among whites in that white bar, 7 whites out of 1,000 had type 2 diabetes. Among Chinese, it was twice that at 15, and then 3 times higher among Koreans, Japanese, and Filipinos in orange. So what's going on? This was 60 years ago. There was no obesity epidemic at that time. Why were these Asian subgroups at higher risk for diabetes compared to whites? This is a study in the Big Island of Hawaii, and this is all based on door-to-door sampling. Filipinos are shown in orange here, and you'll see that they have the same body mass index as whites in the white bar and Japanese in the green bar. So you would expect the 3 groups to have the same prevalence of type 2 diabetes. Instead, it's almost identical to what was seen 60 years ago. So whites have the lowest and highest, and very similar among Japanese and Filipinos. So after the Kaiser data were released, this is when the American Diabetes Association reached out to several Asian American investigators who have their own cohorts. Dr. Xu from the Joslin Diabetes Center at Harvard, Alka Kanea at UCSF. She has a study of South Asians in San Francisco and Chicago. Jane Chang was from the ADA, and Will Fujimoto, who had the Seattle Japanese American cohort study. So for me, as a new assistant professor, I really had no Filipino mentors. And the mentor to me was Dr. Fujimoto. And so try to find mentors who will help you along the way. Dr. Fujimoto is a third generation Japanese American from Hawaii. And I remember running into him at the American Diabetes Association conferences. And he left a lasting impression when he said, "Nobody else will understand your community better than yourself. Nobody else will understand the food and the nuances, the adherence to medications, taking medications or regimens that you use traditionally instead of or in addition to Western medicine. Nobody will be as committed to your community as yourself." And he said, and even if you don't get NIH funding or funding that would help with your academic promotion, don't ever depart from that mission. So we were asked by the American Diabetes Association to identify optimal cut points to screen Asian Americans for diabetes, because the concern is that screening overweight people, defined as a BMI of 25, we might be missing Asian Americans. So thankfully, there was a policy change. And now if your BMI is 23 or greater, you're over the age of 45, the recommendations are you be tested for type 2 diabetes. Make sure you encourage your parents and your grandparents and moreover, your patients and your professors to be aware of these guidelines, which were introduced in 2015, 7 years ago. So why do we have such high risks? Here's this article was published in 2004. You have a man of European descent, Dr. Yudkin, without the beard, and Dr. Yajnik, who is South Asian with a beard. They have the identical body mass index, which is quite low, 22.3. But look at their body fat, and these were by DEXA scans. The South Asian man has 21% body fat despite having a low BMI. So our task was to identify an optimal cut point. And we pulled data from these 4 cohort studies. They had to have no non-Asian admixture, no prior diagnosis of diabetes, had to be over the ages of 45. We assessed type 2 diabetes by either glycosylated hemoglobin, fasting plasma glucose, or a 2-hour glucose tolerance test. And what we found was Filipinos had the highest prevalence at 23. The cohorts in San Francisco were a little younger, and that's why their rates were lower. But here's something that we found is that if screening was limited to people with a BMI of 25, we would have missed everyone to the left where the yellow line is. And that includes a woman with a BMI of 16. So she was 5'4", 95 pounds, and was newly diagnosed with diabetes through our screening. So what would happen if so 1 out of 3 people with newly diagnosed type 2 diabetes would have been missed if screening remained at just a BMI of 25. So the implications are there are at least 500,000 Asian Americans who are undiagnosed. 300,000 could be identified if you screen at a BMI of 23, but about 200,000 will likely not be screened. That includes the woman with a BMI of 16. So another important feature is what test would be appropriate. Typically, a fasting glucose test was a convenient way to assess type 2 diabetes. It required fasting overnight, coming to the lab, having your blood drawn, but then you usually had to take the morning off. So in the year 2010, the American Diabetes Association recommended the use of an A1C measure. You didn't have to fast, you didn't have to take the morning off. You could come in the afternoon. And so, but what we found is it underestimates those who have type 2 diabetes. So in the red bar, that 18% had type 2 diabetes using any of the three measures. If we limit screening to just an A1C measure, it's not going to be 18%, it's going to be just 9%. We're going to miss half of those with type 2 diabetes. If we limit screening just to a fasting measure, it's not going to be 18%, it's only going to be 5%. So the best and most precise way to assess type 2 diabetes is a 2-hour glucose tolerance test. So here it was 15%. And this is recognized in the Philippines also. So when the ADA recommended this, the Philippine Diabetes Association, their leaders reached out and asked if they should start accepting the use of an A1C measure. We published this paper to look at what proportion of Asians would be misclassified if we use this convenient A1C criteria. So these are data from San Diego and Hawaii. So if you use an A1C cut point of 6.5%, it looks like among Filipinos in San Diego, only 12% have diabetes. Among those in Hawaii, it's 8.8%. But if you compare that to a 2-hour oral glucose tolerance test, which is the gold standard, and it is very inconvenient to the patient and to the lab. Patients have to fast overnight. They draw blood at 0 minutes, take a 75-gram very sweet drink, and then blood is drawn 2 hours later. And look at the difference. So if you test somebody with just an A1C test, it only looks 12% will be identified as having diabetes, versus with a 2-hour test in San Diego, it's 22%. It's even worse for Japanese Americans. So if you use an A1C test among Japanese in Hawaii, only 4% will be diagnosed with diabetes, and 2 out of 3 will be missed unless you do a 2-hour oral glucose tolerance test. So what we found was that 6.5% is too high. An appropriate cut point for Filipinos should be 5.8%. And in Korea, they changed their guidelines to an A1C cut point of 5.7%. I mention this because, we're departing from race-based medicine, especially the GFR computations for African Americans. But I think there are some situations, like with BMI, for example, where some race-conscious considerations might be necessary. Otherwise, you'll miss, a group of people who are at risk. So we started the UCSD Filipino Health Study as a comparison group to the Rancho Bernardo study. And again, the motivation was that we had so many dialysis patients who were thin Filipino men. We recruited over 400 Filipino women, followed them for at baseline at 5 years and 10 years. And I'm sharing these data we had 450 in each group, and these are our healthiest women, 200 in each group without any cardiovascular disease. And these are our healthiest women. You'll look at the anthropometric measures, and the African-American women highlighted in yellow had the largest BMI, the largest waist girth, the most truncal fat by DEXA, since we were interested in osteoporosis, and the most body fat. So one would expect the African-American women to have the poorer health outcomes. And what we found was that it's actually the Filipinas who had the highest diabetes prevalence, 1 out of 3, very similar to Kaiser. Whites had the same BMI and the same waistline as Filipinas, but their diabetes prevalence was only 6%, and Filipinas had 5 times higher diabetes prevalence compared to whites with the same body size, and had lower diabetes prevalence compared to African Americans. We were looking at coronary artery calcium, which allowed us to look at CT-defined visceral adiposity. So this is a 6-millimeter slice between the L4 and L5 vertebrae. On your left, you see an African-American woman with a BMI of 25, so she's considered overweight. And if you look at the red areas, that's the harmful visceral adipose tissue. And she only has 25 cubic centimeters. Compare that to the Filipina on the right, 115 pounds, 5'4", BMI of 20, a waistline of 26 inches. Lady, she's probably about a size 2 or size 4. And she's loaded with visceral adipose tissue. 3 times the volume of visceral fat compared to an overweight African-American woman. So who decides, these cut points anyway? And is a BMI of 25 necessarily harmful among African-American women if they have low levels of visceral adiposity? So what we found was that Filipinas have the most visceral adipose tissue. African-Americans have the least. And this has been replicated among people of African descent in England, in the Caribbean, and all over the US. The fat accumulation appears to be subcutaneously rather than as visceral adipose tissue. Regardless of whether a Filipina has like a 23-inch waistline, she still has more visceral adipose tissue compared to white or Black women. And even if you tell them to reduce their waistlines, even at a waistline of less than 80 centimeters, Filipinas still have more visceral fat and over 7 times the diabetes prevalence compared to whites. So this compares women with the least visceral fat and at less than 46, and those with the most. So what you see is this linear curve where among whites, so the blue bar, when they have less visceral fat, only 1% have diabetes. And then the diabetes prevalence increases as they have more visceral fat. But look at the Filipinas, even those with the least visceral fat, 1 out of 4 already had type 2 diabetes. So visceral fat is not the only factor that explains her higher risk. You see these patterns of excess visceral fat among South Asians and Chinese. This is the multi-ethnic study of atherosclerosis. And then again, you see the lower visceral adiposity among African Americans. Another observation we had is that Filipinas have more pericardial fat, more fat around the heart. It's unclear to us why that is. And you see that pattern also among Chinese Americans in the MESA study. So the reasons for this regional fat distribution is still unclear. With the South Asians, it seems to be more hepatic fat accumulation. So what happens when you have a lot of visceral adipose tissue, even if you have a small waistline? So it exacerbates inflammation, it exacerbates your risk for hypertension, for thrombosis, dyslipidemia, and atherosclerosis. So we did measure IL-6 and TNF alpha levels, and they were also elevated among Filipinas despite low BMI, despite small waistlines. We were very interested at that time in looking at adiponectin levels. So in the presence of visceral adipose tissue, adiponectin levels are down-regulated. You want adiponectin levels to be high because the high adiponectin levels play an important role in glucose homeostasis. So there are studies, it's the physician study in Boston that showed that if you have high adiponectin levels, if you have low adiponectin levels, your risk of diabetes 7 years later is higher. If you have low adiponectin levels, your risk of cardiovascular disease is high 7 years later. So we wanted to ask that same question. Do Filipinos have low levels of adiponectin? And what we found was that they do. So Filipinas in orange compared to whites in blue and African Americans in yellow, Filipinas have half the adiponectin levels of whites. And Filipinas with very low adiponectin levels had higher prevalence of diabetes. What's causing this? A study in Cebu found a polymorphism that seems to explain why we have lower adiponectin levels. Well, how can this be useful? Could adiponectin be used as a surveillance tool to identify those who are at risk for type 2 diabetes? There are other groups in, Japan is the leader in adipocyte biology, and there have been attempts to synthesize adiponectin and supplement it to mice who seem to be deficient in adiponectin levels. Could adiponectin become the new insulin for people who have that deficiency? It's kind of hard to synthesize at this point. So another observation is when people migrate from their home country to another country and they adopt the lifestyle and diets of the country that they migrate to, then their risk for diabetes increases. So we wanted to compare diabetes prevalence among people in the Philippines, third and fourth generation Filipinos in Hawaii, and immigrants in San Diego. And what we found was that Filipinas in the Philippines, very low obesity rates, but Filipinos in Hawaii in yellow, about 1 out of 5 had a BMI of 30. So the longer your time in the US, the higher your risk for obesity. What about your risk for diabetes? No difference. What does that mean? Does that mean that diabetes occurs among Filipinos without the presence of obesity? Where else do you see this pattern? You see this among Puerto Ricans. Why is that? We have very similar history to Puerto Rico. We're both Spanish colonies and US colonies, so that our exposure to a US or a Western diet and lifestyle did not require coming to the US. Our acculturation to an American or a Western diet and lifestyle took place in the Philippines. And I remember this as a kid where we had, Shakey's Pizza in Manila, but our friends from Japan did not. So I think it's so important to look at the effect of colonialism when it comes to risks for at least dietary interventions. And the other thing we wanted to ask is, does body fat, does your body size increase the longer you live in the US? And we found no differences, at least in our cohort of Filipinas here. Other factors that increase the risk, what we found is multiparity, having more than 6 live births. I'm the youngest of 7. My mom thankfully doesn't have diabetes, but she blames her expanding waistline and visceral adiposity on me because I was right at the cutoff, being her 7th child. Having low muscle to total abdominal area ratio. So maybe our messages shouldn't, to our to our communities should not emphasize lose weight, but instead build muscle. So you have more effective insulin signaling. We also found that insufficient sleep, sleeping less than 6 hours per night, seemed to be associated with diabetes risk in our cohort. We also had a lot of nurses in our cohort. So when you're looking at risk factors for communities, consider their lifestyles, consider the choices that our family, our community members make just to be able to. I have a sister-in-law who's a nurse. She worked overnight because that was the way they could have childcare. She could raise her family. My brother worked in the daytime. She worked at night, came home, prepared breakfast for the family, took my nieces to school. So could that also be exacerbating a risk? The fact that we are overrepresented in the health sector, specifically in nursing, and so that it's a lifestyle that leads to insufficient sleep, which is a known risk factor for diabetes. Sitting, each hour of sitting, as we are sitting collectively now, increases your accumulation of pericardial fat. Genetic family risk factors such as having a parent with diabetes, but also some of the structural and social determinants of health, lower education, childhood and adulthood, social disadvantage are also risk factors for diabetes. Again, having more children increases your risk for both diabetes as well as visceral adipose tissue. And so increasing muscle mass rather than the emphasis on losing weight, on losing pounds, might be a more effective intervention by improving insulin sensitivity and preventing insulin resistance. Just want to mention this because of the relevance to what's happening now in Ukraine and other war-torn countries. So our cohort of women here were born during World War II. My Lola used to tell me that during the Japanese occupation, there was no food to purchase in Manila. She would have Japanese yen, but there was food was sparse. During the same time at World War II in Europe, the Nazis blocked the roads where food was delivered in the Netherlands. And so what happened is they had very precise records of women who were only eating 400 calories during their first trimester of pregnancy or during their third trimester. And so they followed those people who were gestating back then. And they found that 70 years later, the adults now whose mothers were experiencing prenatal malnutrition, especially in the first trimester of pregnancy, are adults who are at high risk for diabetes and cardiovascular disease. There are studies that have shown that rats who are fed a low protein diet during gestation have impaired intrauterine growth. It results in reduced beta cell proliferation, and that also increases the risk for insulin resistance in adulthood. This was work by Professor Emeline Alejandro, who's a Filipina physiologist and has done a lot of this pioneering work on how a maternal low protein diet alters mTOR expression specifically and its influence in insulin secretion and glucose homeostasis. So the question we wanted to ask is, were these women who were born or toddlers during World War II, were they at higher risk for coronary heart disease? So one way to estimate childhood poverty or growth disruption is to look at their leg length. We measured their standing height, we measured their sitting height, and subtracted the difference, and that gave us their leg length. So leg length, especially in the first year of life, is usually a marker of growth during childhood and is associated with insulin resistance and coronary heart disease when they become adults. So what we found first of all is In our cohort of women who were born before World War II, those who were born during the Japanese occupation, and those who were born after the Japanese left, it was the women who were born before the war who were significantly taller. And those women who were significantly taller and who had longer leg length had a lower risk of cardiovascular disease. So what are the implications in terms of poverty? What are the implications for communities who survived the Vietnam War, who are dealing with malnutrition in Ukraine right now, and other parts of the world where there is a shortage of food, but especially protein diets among pregnant women? Gestational diabetes is a risk factor for type 2 diabetes, and the Kaiser data also shows that Asian Indians, Filipinas, Southeast Asians, Chinese, and Pacific Islanders have a higher prevalence of gestational diabetes compared to Latinos, Blacks, and Whites. But what you're probably going to hear in your lectures are it's preconceptional obesity. Women who were pregnant during gestation are those who are at risk for gestational diabetes. These data from Kaiser, enriched with a large population of Asian Americans in California, tell you otherwise. These are Asian women, including Filipinas, who were not obese before conception that had the highest rates of gestational diabetes. And we know that about half of them will develop type 2 diabetes within 5 years. This pattern persists in San Diego. Immigrants in green had higher prevalence of gestational diabetes, with Filipinas who were born in the Philippines having the highest rates of gestational diabetes. So what do we do about prevention? We have the diabetes prevention program in 26 sites, and over almost 20 years ago, the big news then was if you randomize people into a drug, metformin, lifestyle intervention, so they have to exercise 150 minutes a week, they have to lose 7 pounds, 7% of their weight, versus placebo. The big news then was that if you give them metformin, that reduces the risk for developing diabetes 3 years later by 31%. But the best thing is lifestyle intervention. So that reduces their progression from prediabetes to type 2 diabetes by 58%. So it works really well. And if you can't exercise, metformin is a great way to prevent that progression, especially if you have a high BMI. So if your BMI is greater than 35, prescribe metformin. That reduces their risk of developing diabetes by 53%. But what population did not benefit from metformin? It was people with a low BMIs. And in the DPP study, they were mostly the Asian participants. So those who received metformin, that only reduced their progression from prediabetes to type 2 diabetes by 3%. In fact, the DPP study in China showed that metformin was not effective at all in delaying the progression from type 2 diabetes from prediabetes to type 2 diabetes. So as you're reading journal articles and you're trying to decipher which interventions are helpful, please keep in mind who the populations were, who participated, and who did it benefit and who did it not, and who was not represented in the study. So some of the practical interventions would be to increase muscle mass. The big question is, why do Asian Americans, especially Filipinos, accumulate excess visceral adipose tissue? The practical question is, how do you get rid of it? You can't, it's intra-abdominal fat. You can't liposuction it out. Interventions have focused on weight loss. We need to focus on building muscle. So I'd like to transition now into COVID-19. So we know that our communities were heavily impacted, and it wasn't just the nurses. But for those who are unfamiliar, 4% of nurses in the United States are Filipino. And when this was published last year, 1 out of 4 nurses who died of COVID were Filipino. Here in California, 1 out of 5 nurses are Filipino. But of the nurses who died of COVID in California, 70% were Filipino. In Santa Clara County, which is up by Silicon Valley, when you look at all Asians together, these are COVID cases in the first year of the pandemic. You'll see that compared to all other Asians, Filipinos and Vietnamese had rates of COVID infection rates that were just slightly lower than African Americans. And in Manitoba, Canada, where there seems to be a growing population of Filipinos, the Southeast Asians, African migrants, South Asians, and Filipinos had higher infection rates of COVID compared to Blacks, whites, and Chinese in Canada. And these data are rare because all of the COVID data have been reported aggregately with Asians. Hawaii is the only state that routinely disaggregates Asians, and you'll see that among that Filipinos and Pacific Islanders had high COVID infection rates. This persisted during the Delta surge. And when it comes to mortality, Filipinos as well as Japanese and Pacific Islanders had the highest mortality rates. In California, if you look at Asians, their COVID mortality rates seem to be lower, better than whites. But if you look at the Asian subgroups, the Latino COVID deaths are marked with a green horizontal line, and look where Filipinos are. So Japanese, Cambodians, and Filipinos had the highest COVID deaths among in California, and with Filipinos, it was very just slightly. It was very similar to the Latino COVID deaths. And this paper was published by Dr. Oronce, who is one of the leaders in CFAM. And what you see here among deaths in California, you see the share of the population in the dark green. So for Japanese, for example, it's about 3% Japanese American in California, but then the share of the COVID deaths is less than their share of the population, whereas it's reverse for Filipinos. So we comprise about 22% of the share of the Asian American population, but over 42% of the COVID deaths among Asians. We were able to get data from the San Diego COVID deaths, and you see that in San Diego, Native Hawaiians and Pacific Islanders, and then Filipinos, followed by Mexicans, had the highest COVID death rates in San Diego during the first year of the pandemic. What else is unique? Even though most of the deaths in the first part of the pandemic were among elderly, whites comprised most of the older deaths. American Indians and Alaska Natives had more women than others. But look at Filipinos. Filipinos had 35% of those who died of COVID had type 2 diabetes. So we, along with Mexicans, had the highest proportion of COVID deaths who happened to have diabetes. This was published recently, where about 40% of the 1 million COVID deaths in the US had type 2 diabetes. So that seems to explain why COVID deaths among Filipinos were so high, whether they were healthcare workers or not. And so that concludes the presentation. I just wanted to acknowledge the funding that we have collectively received from the NIH. And I look forward to this part because this is our conversation, and this is when we can have a dialogue.
Thank you so much, Dr. Araneta. If you could stop sharing your screen for a second. Before people start leaving, if you need to go, please do so. yeah, because we're at the end of the hour, but Dr. Araneta has happily agreed to stay for a tiny bit to answer some questions. But before we get to questions, if we could take a group picture, that would be great. And if Carla, you could set up that up. If people can, just turn on their cameras, that would be great for this.
Okay, retaking.
All right, I will take the photo right now.
Can we do it by gallery? Because I'm seeing.
Yes, it's gallery on my end.
Okay.
1, 2, 3. All right, thank you, everyone.
Thank you, everyone. So if you want to ask Dr. Araneta a question, please raise your hand. But also before we get started, if you're interested in getting involved with AFSA or CFAM, just follow the links here or the QR codes as well. So our first question will come from Rose. I'll keep this up for like a minute and then we'll transition back to gallery.
Hi, good evening.
Evening.
Hi, can you hear me? Sorry, I have a baby right here. Thank you so much. That was such a great presentation. And it just makes me so happy to hear like scientists talk about, you know, fat percentage rather than just BMI. Because when I was getting my bachelor's back in the day, I was like, oh, we have to look at body fat percentage, not just BMI. So that was really, really fascinating. My question, what really struck me was the interleukin-6 and inflammatory, like high levels of inflammation. And I study COVID-19 on like moms and babies at MGH. And one of the things that has been interesting is interleukin-6 also, and how that might be like a target for COVID-19. And then the article about how there's an increased percentage of Filipino nurses. Do you think that there could be a link where the reason why a lot of our Filipino nurses, you know, were affected by COVID-19 was because there was already naturally have a high elevation of interleukin-6, and then pair that with COVID-19 further exacerbates, and then yeah.
It certainly might. So I think anyone who was at risk for inflammation seemed to be at risk for COVID infection. It was always the ACE2 receptor cells that seemed to be of concern, and but I think any inflammatory pathway was made us vulnerable. So in my family, I'm the youngest of 7, and among all of our collective close friends, we lost 17 people to COVID.
I'm so sorry. Thank you so much for answering my question.
Well, thank you for looking into that as a possible mechanism, and then hopefully as an intervention or identifying those who might be at risk.
So our next question came to me by direct message from the chat. Oh, so what are the significant and common confounders found in your research, and how were they controlled for?
The most important confounders in any study is participation bias. So these were 453 women who volunteered. They were not paid. And so we were enrolling them to a study of osteoporosis to reduce any bias in recruiting people who had cardiovascular disease or type 2 diabetes. So that was a way we were able to circumvent it by marketing it as an osteoporosis study. If you ask yourselves, have you ever joined a clinical study? I have not, but then I wonder, who are these people who are willing to spend 4 hours of their day to get poked and questioned, and how are they different from people who don't volunteer? I also think that the people who we enrolled in San Diego are predominantly reflect the history of Filipino migration to San Diego. So they're represented by a large Navy community or wives of members of the Navy. A lot of them come from certain regions, from Cavite, from Bicol, so that if we were to look at regional differences in the Philippines, and there are, so the Philippines does door-to-door sampling. They cover 500 islands. So this, and what they're finding is they're finding differences in cardiovascular risk factors by island. So it's lowest in Mindanao. I don't know if it's because many follow a halal diet, and they also tend to be big producers of agricultural products for Malaysia and Indonesia. So if there are risk factors, whether it's dietary or genetic that we're still unaware of, that are differently represented from the different regions, we didn't have that kind of regional diversity in San Diego. We have very few Visayans here. So, so that's another factor.
Great, thank you. Jaylor, you wanna go?
Sure. Thank you, Dr. Araneta, for your talk. I was wondering, going back to that idea of the A1C versus the fasting glucose, and how you were saying that an A1C of greater than 5.7 is more in line with a patient who is Asian who has type 2 diabetes. What is the clinical picture that you're working with that kind of states that is the true positive result, and why isn't it? Because I know from definition from the textbooks we read, it's either fasting glucose or A1C that makes you a true positive. So how do you kind of correlate the two together?
So we ended up with that suggestion of a 5.8 cut point based on retinopathy. So we had the ability to, we did fundal photographs, and we were able to identify, and so that was our cut point in defining a 5.8. We haven't put out a position statement on it, but that seems to be, so 5.7% seems to be the definition for pre-diabetes according to the American Diabetes Association. But we published that with the goal of precipitating conversation among other communities. I know A1C is also kind of controversial among patients with the sickle cell gene, for example, or other hemoglobinopathies. And then in Korea, their recommendation to use a cut point of 5.7% were also based on retinopathy.
Okay, sounds good. Thank you.
Okay.
Okay, Carl, you can go next.
Hello, can you guys hear me?
We can hear you.
Oh, cool. Thank you. Oh, yeah, great talk. Really, really informative. To piggyback on the first question, I think it was Rose that asked the question about the elevation of the pro-inflammatory cytokines in diabetes. You mentioned that there's like a regulation of the IL-6 and then the tumor necrosis factor A in diabetes. Would that elevation of like the inflammatory cytokines accelerate the development of type 2 diabetes that patients that contracted COVID-19? Or I'm just like curious about that.
Yeah. I don't know. So so the increase in TNF alpha as well as IL-6 is evident in those with a lot of visceral adipose tissue. So even if you don't have type 2 diabetes, you'll see that IL-6 elevation, the TNF alpha elevation, that's also associated with cardiovascular disease independent of type 2 diabetes. Whether or not that accelerates the severity or of COVID-19 and diabetes is still, I don't know. But certainly likely, especially if you've got those inflammatory pathways as well as, you know, ACE2 receptor cells that are often that are target of COVID-19.
Cool. Yeah, thank you. So I'm just interested because my line of study just focuses on like pain-related behaviors and all that.
Okay, so our next question is asking you to speak to the findings related to multiracial Filipinos.
That's something that's it's very relevant. And how do we identify that even with somebody whose four parents are all Filipino, like mine? So all four parents are Filipino. We did the genetic ancestry. And according to Ancestry.com, I am 30% Samoan or Tongan, 6% South Asian. So does the Samoan and Tongan make sense? Everything depends on the reference pool. So who else is on 23andMe or on Ancestry.com? If you look at linguistic patterns, how we have a short alphabet and we tend to repeat words to create a new word, halo-halo, kare-kare. And so the 30% Samoan or Tongan was intriguing. 6% South Asian. The Indians went to the Philippines in the 12th century, and that's why you see a lot of curry-based dishes in the Bicol region. And there was a time in history when England colonized certain islands of the Philippines, and they brought Indians to work on the railroads. What else? 7% Uzbek. So we're from the south. Indonesia is the largest Muslim country in the world. Was Islam introduced to Southeast Asia through Uzbekistan? 3% Native American. Is that a fluke, or is that a result of 300 years of the Manila-Acapulco galleon trade, where the Spaniards brought 70,000 Aztec and Guerrero Indians who rowed the boats, brought goods from Peru, and they went to Manila. Are you all familiar with Mexico, Pampanga? There's a town in Pampanga called Mexico, and it's spelled like Mexico. And it has the same altitude as Mexico City. And so historical records suggest that that's where a lot of the 70,000 indigenous Mexicans settled. And is that where we got the 3% Native American? More fascinating, if there is a diabetes gene, is that how it was introduced to the Philippines? I think it's just a fascinating intersection. So this is from someone who I consider myself to have no genetic admixture. All four grandparents are Filipino. I think, with so many admixed generations to follow, I think it becomes very challenging. Studies in Hawaii have shown that Native Hawaiians with white admixture have lower risk of diabetes compared to Native Hawaiians where all four grandparents have type 2 diabetes. So there seems to be some kind of protective effect with European ancestry.
Thank you so much, Dr. Araneta. Just clarifying, when do you have to go per se?
I'm okay. I can go till 6. I'd rather be able to respond to your inquiries, and thank you for the very thought-provoking questions.
Okay, so our next question comes from the chat. How do you think we as scientists, public health advocates, and clinicians can best translate this Filipino disaggregated health data into Filipino community health interventions and messaging, as there has been a lot of disinformation spread on social media regarding Filipino health, from COVID cures with salabat, vitamins, to lack of proper info on diabetes. And I would love to hear your ideas on how we can all be more vocal, more strategic in our fight against this disinformation.
It's been a frustrating struggle. So here in San Diego, the largest minoritized group are Mexican Americans, and following that are Filipinos, and number 3 are African Americans. And so we knew when people in our community were dying, and we were working very closely with the health department, asking them to disaggregate Asians. The only proof that we had was when we contacted the contract tracers and we asked them what languages are most frequently requested. And that's when they said Spanish first, Tagalog second, and Arabic third. Arabic surprised us because they're misclassified as white. And San Diego is one of the second largest receiving communities for refugees and asylum seekers. So it turned out Iraqis were number 3. So I think finding other resources to document where you have an excess in our community. Another resource, I was contacted by the LA Times, and they said, we're finding, Filipinos are dying compared to other Asian groups. And I was like, how did you find out? And let us know the resources. So the LA Times offered free obituaries. And that's how they knew that Filipinos were dying, because, this patient passed away, was born in the Philippines. So get information locally that depart from the usual reporting mechanisms, that depart from the health department, find other ways to document that. And so that was the only evidence that we had for to argue to the health department that we need brochures in Tagalog, and not just Tagalog. There's so many, people from Pampanga and other areas who don't speak Tagalog. How do you fight disinformation on Facebook? I think that has to, and unfortunately, that disinformation has persisted even with the recent elections. It's expanded even with the elections in Brazil. It's something that I hear that too with some of our medical students who are arguing on Facebook with their lolas, because the lolas saying, just take Salabat, it fixes everything, or Vicks, and I think just if there were some of our Latinx students created a Facebook page with that same purpose, to create a space where they have factual information, where they respond to traditional methods and why they might not be efficacious, but having a collective voice. But it really is challenging. There's no regulation in social media.
Angela?
Hi, Dr. Araneta. Thank you for your talk today. I just had a question about gestational diabetes and what you recommend. How do we counsel patients to try to prevent gestational diabetes?
I think the usual recommendation is to have optimal weight gain to provide to have a healthy child, but not excessive weight gain. It's more challenging in the Philippines. I was at a conference right before the shutdown, and they actually identified genes that were associated with GDM among Filipinos in the Philippines. I think recommendations, to stay, to keep active, to move, just so you have enhanced insulin signaling and sensitivity. But I think the recommendations I think it would be hard to restrict weight gain if that means resulting in intrauterine growth retardation for the kid, for example. So aside from the genetic factors, I think, keeping active and walking.
Thank you. Yeah, I was figuring maybe like increasing the muscle mass would still be important for even before they become pregnant.
Yeah, absolutely. There have not been any clinical trials on increasing muscle mass. So how much and how and which areas, that still hasn't been cleared yet, whether it's to achieve X% muscle mass. I think that would be a great project for a student.
Thank you.
Anyone else have any other questions?
So I left my email in the chat up above. I'm happy to do that again. Oh, there's a question.
Edna?
Hi, Doc Happy. Thank you so much for your very, very informative and very well-researched and rigorous information on diabetes, and also the whole study design for this epidemiological study. My question is, because I'm in the process of doing my dissertation and looking for a topic. So would you suggest something, because my co-advisor is also we're currently looking into the NLAAS, the National Latino Asian American Study, and it's actually quite an old database. Is there anything you would suggest that we can look into, not in the NLAS per se, but something that still needs to be researched or looked into in relation to what you just presented?
I think
from the epidemiological standpoint.
Yeah, so I'd be happy to chat offline. Another resource is the study of Latinos, which is still ongoing. It's a prospective study, and I think they have over 16,000 participants. But I put my email there, Edna, and I look forward to brainstorming with you.
Okay, thank you po, Doc Happy. Thank you so much.
Walang anuman.
Carl, did you have another question, or is your hand still raised?
Oh yeah, I do. Yeah, another question. The people that are diagnosed with diabetes also overconsume NSAIDs or other analgesic drugs, given that there's a elevation of their inflammatory.
So that's an interesting question. We did ask about all medication use, including over-the-counter drugs, and we haven't looked at that yet, actually. That would be a good thing to investigate.
Okay, cool. Thank you.
Okay, well, if no one has any other questions, Dr. Araneta, thank you so much for taking the time to speak with us today. Your data was really, really interesting too. As you could see, a lot of us here. We appreciate your time and your efforts to help disaggregate the data among Asians, which hopefully can better inform our community as a whole. So thank you so much.
My pleasure. And I hope you won't be shy about contacting me by email if you need to just some guidance about research projects. Gout is a huge problem in our community. So I think one way to become inspired is to look around your own family, what has impacted your family members disproportionately, and the only way that we can advance addressing health inequities in our community is if we could do it together. And I'm so proud to see so many scientists and future physicians on this call.
Thank you so much, Dr. Araneta. As you said in your talk early in the beginning, you couldn't find a Filipino mentor. So for us, this problem still very much exists. Mm-hmm. So, thank you for being a source of inspiration and a source of kind of guidance for, our community.
My pleasure. And some of it was luck running into a department chair, but with that luck and that privilege comes responsibility. And if it's handed to you as a gift, you can't turn it away.
Okay.
All right.
Thank you so much.
We'll look forward to seeing you all in June with Dr. Ponce.
Yes. Okay. Bye, everyone.
Bye.